Thank you, RT. Experience is simply the accumulation of your mistakes. And I have plenty of experience, some of it quite painful. But I would like to thank the organizers for the invitation to speak and the topic of transposition. I've widened it slightly, but how early is too early and how late is too late? Well, this is transposition. That's the aorta arising. And how do we know it's the aorta? Because there's a coronary coming from it, arising from the right ventricle, and there's the pulmonary artery arising from the left. So transposition, I don't want to be too basic, but it is not survivable postnatal life unless there is some communication between the two circulations at the level of the duct, or at the level of the atrial septum through an ASD, or sometimes there's a ventricular septal defect, which enables mixing of the circulations. The best place for mixing, however, is through the atrial septum. So postnatal, the first objective is to maintain the duct with prostaglandin and then to echo the direction of flow through the duct to give some indication of pulmonary resistance. And it may be on that basis that we can stop the prostaglandin. The other important feature of the echo, of course, is to look at the atrial septum to assess the size of the communication and the direction of flow, which hopefully is mostly left to right. And if there's a VSD, again, to assess its size, location, and the direction and volume of flow that is crossing, and hence the degree of mixing. Now, many of the cases of transposition will be diagnosed antenatally, though it is one of the more difficult lesions because there is generally a normal four-chamber view. But that may establish the diagnosis, and so the fetal cardiographer is looking to see the size of any atrial communication, which is crucial to postnatal management. And the nature of the flap valve of the atrial communication may also give some indication. Is there a VSD? And of course, are there any additional defects such as coarctation or interruption? So postnatally, things improved massively when Rashkind introduced the balloon septostomy. And I certainly, as an operating surgeon, favored balloon septostomy in most cases before they went to the operating theater, because I like to use a single venous cannula, and so that enabled better drainage of both the right and left atrium. It was simpler, but it also tended to avoid sudden changes in oxygen saturations and panic, resulting in a call to the surgeon saying, we've got to take this baby to surgery. I never liked having to rush into operations. So back to antenatal assessment. If there's a small or no atrial communication, then clearly post-delivery oxygen saturation may be dangerously low. And as a consequence, an aneurysmal atrial septum, quite commonly seen, is not apparently predictive of poor mixing post-delivery, but may, on the other hand, respond poorly to a postnatal septostomy. So fetal atrial septostomy has been attempted in selected cardiac defects such as HLHS. So could it be useful for transposition with a restrictive or no atrial communication? I searched the literature and eventually found some mention of it in a paper. And here you can see an aneurysmal atrial septum. But here is the case with an intact atrial septum, and this was described in 2018 by Mawad and colleagues, and they performed an atrial septostomy at 37 weeks, delivered the baby a week later, and it underwent a successful arterial switch at 7 days of age. And this was the technique, so it transabdominal directly into the atrium. Unlike the Rashkind, where it's a pullback, which is not possible, so it was a static balloon dilatation, and with, I think it was 3.5 millimeter balloon, enabled sufficient communication to have reasonably stable postnatal life. So Should we be attempting a post-fetal septostomy in the context of transposition as an initial treatment where there is an intact or near intact septum? Now, unlike hypoplastic left heart syndrome, where we do see intact or highly restrictive atrial septum, there shouldn't be any impact on the pulmonary venous, or it shouldn't cause pulmonary venous hypertension leading to an elevated pulmonary vascular resistance, because there is otherwise unrestricted flow of the pulmonary venous return from the lungs in transposition, unlike with an intact or restrictive septum in hypoplastic left heart syndrome. So on that basis, I think it is very hard to justify a procedure on the fetus with the risks to the mother and the fetus itself, except in some carefully selected and well-informed cases. So, should it be performed, I think that it'll be better to consider a planned delivery at a pediatric cardiac center, which is mandatory, with the necessary personnel on hand. So postnatal care, well, prostaglandin is almost invariably commenced until we know the nature of the VSD and the ASD. And as I said earlier, an atrial septostomy should be anticipated and all the personnel and equipment prepared for immediate application, because these babies can be very hypoxic immediately after delivery. And if so, they may require intubation and ventilation with supplementary oxygen, nitric oxide if the ductal flow indicates elevated pulmonary resistance, and all of these features are important. So, timing of surgery. Well, the prime objective, of course, is to obtain the best outcome for the baby. But a secondary objective is to provide the best experience for the mother and the immediate family, which will be facilitated by an antenatal diagnosis with a full and honest explanation of the procedures that are likely to be necessary. After birth, and we need to pay attention to all the obstetric priorities, confirm that there's adequate oxygen saturations, and then allow the mother and family to bond with the baby. And plan the date for the arterial switch within the next 2 weeks, providing the baby remains stable. So in the context of poor oxygen saturations, we need a chest X-ray, first of all, to check that the lungs are adequate, there's no pneumothorax and a cause there, because rushing to theater with it because there's a pneumothorax is clearly not the right thing to do. Give some oxygen to try and counter high pulmonary resistance. As I've said, consider intubation and ventilation, plus or minus nitric oxide, and the echo to see if the duct is still patent, and if not, to increase prostaglandin. And is the septostomy allowing good mixing? Now, the fact is that despite a perfectly good atrial communication, some babies do not mix well due to streaming. And when there is a very floppy atrial septum, the septostomy may just sort of pull through it, but actually not tear it and fail to enlarge the communication, resulting in persisting cyanosis. So persistent desaturation is an indication for an urgent arterial switch operation, especially if there is acidosis and raised lactate in the context of the hypoxia, but do beware of a raised pulmonary vascular resistance as the cause, because that will plague you for sure after an arterial switch if it persists. So in the absence of any of these clinical factors, I don't think there's any justification for an arterial switch operation on the first day of life, because maternal bonding is important. Breastfeeding is not contraindicated, though NEC does have to be guarded in the context of a prostaglandin infusion. And the introduction of the baby to the wider family is socially and psychologically important for all concerned. Pulmonary vascular resistance is labile through the first week of life and could cause problems in the recovery phase. And other processes of maturation of other organ systems do happen through the first week of life and may facilitate a smoother post-operative recovery. So in my view, surgery in the second week of life is a good objective, by which time the clinical team will have come to understand the baby's pattern of clinical behavior, which should help in the management post-operatively. Now, moving on, when is it too late? Well, in fetal life, the ventricles work against the same resistance, with the arterial duct being patent. In postnatal, while the arterial duct remains open, the left ventricle will face the same pressure load as the right ventricle, and usually a greater volume load. The same will happen in the context of a large VSD. When the duct closes, the pressure load on the LV falls as the pulmonary vascular resistance falls, and volume loading reduces on the left ventricle. So when the duct closes, the LV workload falls, and after 2 weeks, muscle mass starts to reduce. Left ventricular wall thickness on echo then starts to reduce, and the left ventricular shape alters with bowing of the ventricular septum towards the left, giving the orange and banana short axis view that we will see on echo. And by 4 weeks old, the left ventricle may no longer be able to assume the workload of supporting the systemic circulation, so that an arterial switch operation may fail when we try to wean the baby from cardiopulmonary bypass. So growth of the neonatal and infant heart. Well, during fetal life, the heart grows by adding myocytes, hyperplasia. And hyperplasia continues after birth, but gradually stops, and further growth beyond that period is by hypertrophy of the existing cardiomyocytes. We know that in rats, cardiomyocytes will double within the first 3 weeks of life, and thereafter this process stops. And in humans, hyperplasia of the cardiomyocytes slows after birth and may have ceased by about 6 months, though we're uncertain as to exactly when that occurs. So when hyperplasia stops, growth continues by physiological hypertrophy. The hypertrophic phase of growth is by lengthening and widening of the existing myocytes. And this is accompanied by a corresponding growth of the capillary network to maintain a constant intercapillary distance and to therefore properly perfuse and supply the cardiomyocytes with oxygen and all the substrates they need for normal function and metabolism. But later in life, hypertrophy from hypertension or aortic stenosis is a pathological process, as there is no corresponding increase in capillary network. So the transition from fetal to neonatal life results in a 25 to 30% increase in ventricular volume load. The interruption of the placental circulation increases the systemic vascular resistance and thus the left ventricle afterload in the context of a normal heart. The expansion of the lungs and resulting fall in PVR decreases RV pressure load, and postnatal RV growth hypertrophy is stimulated by volume overload, but postnatal left ventricular growth is through hypertrophy is stimulated by pressure and volume load. So by 1 month, the normal heart, the left ventricle outweighs the right ventricle. But in transposition, the postnatal LV is only keeping pace with the demands of the pulmonary circulation. So late presentation, and by that I would mean beyond 4 weeks, the factors to consider: is the duct open and by how much? And is the left ventricular shape now a banana? How thick is the LV wall compared to the right ventricle? If there is no duct and a banana-shaped LV, thin-walled, it is likely too late for a successful primary arterial switch. The left ventricle is unlikely to support the systemic circulation postoperatively in this context. So what are the options? Well, one is to perform the arterial switch and use mechanical support postoperatively with ECMO to retrain the left ventricle to take up the systemic circulation, or alternatively, rapid retraining of the left ventricle utilizing the coronary artery band and a shunt followed by the arterial switch. And this can usually be accomplished within less than 1 week. And both of these options are applicable in the first 6 months of life and probably first year of life, maybe up to age 2 years. Early in the introduction of the arterial switch, after Jatin described it, the operation was a real challenge in the neonatal period, owing mainly to technology and all that supported cardiac surgery at that time. And Yakub developed the two-stage procedure by banding the neonate and then performing the arterial switch later towards the end of the first year of life, and achieved acceptable results. And Jonas in '89 introduced the concept of the rapid retraining using a band and a shunt in order to achieve an arterial switch. And then the alternative of using ECMO to support the left ventricle postoperatively was introduced by others. And both banding and the ECMO support seem to show similar outcomes from literature review, but very few draw a conclusion on what age is too old. So, are there lessons that we can learn from congenitally corrected transposition? Because there is quite an experience of retraining the involuted left ventricle with a view to the double switch procedure. That operation was introduced in the early mid-90s and became quite popular throughout the early 2000s. And there were publications on the merits and methods of left ventricular retraining and publications proclaiming what they would describe as excellent results for the operation itself. And Winlaw and colleagues in 2005 published early results and suggested that the maximum age of successful retraining would be 16 years. Poirier and all and colleagues from the experience in Melbourne and in the Cleveland Clinic suggested a maximum age of 12 years for left ventricular retraining. But I emphasize these were relatively early reports. Myers, reporting in 2013, observed that there was a 67% incidence of left ventricular dysfunction within 2 years of the operation in patients who were aged more than 2 years old at the time of the double switch procedure, whilst in those who were less than 2 years old at the time of the double switch procedure after retraining, there was a 0 incidence of left ventricular dysfunction. And that, to me, suggests that there is therefore a point beyond 2 years when the left ventricle may be unable to, you may be able to retrain the left ventricle to enable an arterial switch operation, but that the longer term outcome may be no better than if we were to perform an atrial switch, mustard or Senning procedure, because the left ventricle will show signs of failure. And this may be that it is past the phase of hyperplasia and physiological hypertrophy that will enable it to function as a normal and adequate left ventricle for 70 or 80 years. So those are my observations. The data to support the exact timing is limited, but caution is the message. Thank you for your attention.
Your excellent talk. It was very touching that you mentioned twice the bond of mother and child that we many times overlook in our lives, and it is very important. Is there any questions from the audience? Can I ask something? What would you consider a baby that can wait for 1 week to have the operation? Because many times we have babies that are intubated, or there is fluctuation in their saturation, and sometimes there is infections also, or and I wonder what would be the best politics for this?
What would be the minimum time from birth to switch these days?
Well, I have done a couple of arterial switches within 24 hours of delivery because they were hypoxic. The atrial septostomy was performed, gave a decent communication, but one was a typical floppy septum and just didn't tear, and you know, there was no improvement, and short of a surgical atrial septectomy, it wasn't going to be helped by any other means. The impact of low oxygen saturations, of course, cannot be dismissed, but the ability of the neonate to extract oxygen is remarkable. And what's really important is that there is good systemic perfusion. If there is high pulmonary blood flow and relatively low systemic perfusion, then that may lead to lactic acidosis, and that's important. And if it's a consequence of low flow or low oxygen, or a combination of both, then you really got to do something about that, because that is, you know, leading you towards renal failure, gut failure, and the impact on the cerebral circulation and subsequent neurodevelopmental issues, etc. So that would be a reason to get on with the arterial switch. But if lactate is normal, acid-base balance is normal, and all organs are functioning normally, I think rushing to the operating theatre may not solve the problems. If you've got high pulmonary resistance, or you've got problems with lung function, an arterial switch is not going to cure that. And so you need to be sure that you're actually dealing with the right element of problem.
So if we have a sick child, then fine, we do a septostomy. If he improves, fine. If he doesn't improve, we go to theaters. If we have a stable child, what is nowadays the optimum timing of a switch operation? Is it still 1 week? Is it 2 weeks? Is it 3 to 5 days? David and Connell, please.
My personal view would be somewhere between within the second week of life.
Yeah,
I'm not doing switch operations anymore.
You've done enough of them, David. David and I used to compete to see who would get the children on the table. So I think if you looked at our results going back over the past 20 years, I think more than 10 years ago, we would have been doing children within the first week. And I think that's changed to doing the children in the second week. So normally what's happening in our department currently is if a baby is presented to us on a Wednesday meeting, we'd be looking towards doing that operation towards the latter part of the following week or the early part of the week after. So usually certainly less than 2 weeks. You have to watch the babies very cautiously and very closely. If there's any signs of necrotizing enterocolitis, you need to be very careful about that as well. So I would say within 7 to 14 days is the ideal period, and that's what we'd aim for in our department if it's a standard arterial switch operation.
That's really impressive. You're saying that you're doing it between 7 and 14 days of life, because as Dr. Komnu said, we have noticed that waiting for that time period in the NICU, a stable baby, a well baby, can turn into an infected baby or a baby that starts compromising, becoming tachypneic, etc. So it seems that we cardiologists have been hassling the surgeons to do it earlier. So Dietmar Schranz seems to believe that we don't need to do septostomies anymore, that in China they don't do septostomies anymore, where places are extremely experienced, they've got huge numbers, and that surgeons go straight to surgery with patients from birth, anything from labor ward to, which is, you know, it sounds really very drastic, but from labor ward to NICU to a couple of days of life. And so do you think that we are moving towards this direction? Towards earlier switches?
I think we're moving in the opposite direction, to be quite honest with you, Aphrodite. I think yeah, if you looked at what David and I were doing 10, 20 years ago, I think we were doing them sooner, and now we're actually leaving them later. Certainly about a week to 10 days, 2 weeks. It's not uncommon.
Yeah, I think that's my impression of the trend. A lot of these sort of emergencies, you find that sometimes if you just sort of think a little and the heat sort of settles and you get just as good an outcome. Doing an arterial switch and starting it late in the evening is not really ideal. Bringing the baby out of the operating theatre at midnight, where reduced numbers of staff, everybody's feeling rather tired and weary. Better to try and do it, a planned procedure when everybody's on top form and properly prepared.
Yeah, that makes absolute sense.
I interfere, Aphrodite. This is our experience too in our center. We like to go later to do the operation, around 7 days of life. We do not do constantly atrioseptostomies. We are waiting a little bit, and only the kids that they show signs of any kind of complication that we have to wait a little bit, we go for elective atrioseptostomies. This is our experience from our center. The preference is around 7 days, I would say here.
Well, that was Marinos, from what I understand, Kadzis, from the UK as well. So we had a question from the audience. From your experience, septostomy and repair in 1.5 weeks is indeed preferred than early repair in 2 days of life. So I think you've answered these questions, the experts. So it seems that median time is around 1 week of life. But again, it is very important that we don't wait too long, because, as I said, infections and the compromise of a stable child is really not good. And we had a question that came through to us quite late about the previous talk, but luckily Connell Austin is still here with us. And the question is, would you comment on the proportion of neonates with tubular hypoplasia of the entire proximal and distal transverse arch, which require an open approach, versus the neonates with distal arch hypoplasia, which can be easily repaired via a left thoracotomy, with possibly an extended anastomosis, of course, excluding cases with concomitant intracardiac lesions, which need concomitant repair for other things. So, Connell, please.
Yeah, it's a hard question to answer because it all really depends on the anatomy. I think, as David mentioned as well, you've really got to know what the anatomy looks like. And I think the ultrafast CT scans that we do now are very helpful To me, the important bit of the transverse aorta is the proximal bit, so the bit between the brachiocephalic artery and the left common carotid. If that bit is going to remain hypoplastic or relatively small after you've done an extended thoracotomy coarctation, I think that will be setting up problems for the future. I do think that we're becoming a bit more aggressive with our transverse arch narrowings. And I think that we're taking more patients for sternotomy repair and arch augmentation. I do remember whenever I was younger training and listening to a surgeon from Dublin, Freddie Woods, and he gave a very fantastic talk about radical extension of the coarctation hypoplastic arch repair through thoracotomies. And I wouldn't really have had the nerve to get my aortic cross clamp right along to include half of the brachiocephalic artery. Also, it's very tense. So in terms of percentages, I think we're shifting away perhaps to being a bit more aggressive in dealing with hypoplastic proximal aortic arch narrowing to try and make the long-term hemodynamic benefits of a wider aortic arch better for the future.
Thank you very much. Yeah, thank you very much. And if I may add, I just want to reinforce what Mr. Austin said, that we cardiologists should be asking our surgeons to address the transverse arch hypoplasia at the same time with the coarctation, whether that can be done via an extended repair via lateral thoracotomy if the surgeon thinks so, but many more times these days the surgeons go via midline sternotomy in order to sort out the arch as a whole, because it seems that in the adolescent population and the adult population that we come across these days, we interventionists come across these days, we get a recoarctation and sometimes we get referred patients to put a stent. And then we see that the patient also has transverse arch hypoplasia, because those days lateral thoracotomies were addressing the isthmus, the isthmal stenosis, and not the transverse arch hypoplasia. And at the beginning of my solo interventional career, I had a 17-year-old patient with a stent, where I put a stent for recoarctation, but his transverse arch was really borderline, and he continued to be significantly hypertensive. The comment from my Australian colleagues, where the patient afterwards went to, were that they wouldn't have put a stent, and they would have taken this 17-year-old patient back to theaters and to have done an extended arch repair at this age. So addressing the transverse arch is really very important for the surgeons and for us interventionalists. If we see it at a later stage in adolescents or even adults, it might be the case that we should not put a stent, but rediscuss that with our surgeons in order to solve the whole problem. Good. So thank you very much indeed. That were fantastic talks. Thank you to my co-chairs, Dr. Komnou, Professor Anderson. And because most of the people are online, there's many people watching us. We are not going to have a break. We're going to transition to the next session that will be chaired by Professor Vlachos, Dr. Giannakopoulou, and unfortunately, Ria Apostolopoulou has a problem, and therefore, Dr. Saris will chair in her place. So we look forward to that. Thank you all.